Hey everyone, welcome back to our Masterclass series. In this explainer, we're stepping right into the shoes of expert clinical documentation improvement specialists and medical coders to decode an absolutely massive clinical shift. We're talking about the Sepsis-3 revolution. For years, our medical and coding communities leaned heavily on older, generalized frameworks, but that landscape? It has completely transformed. Today, we're going to break down exactly what that means for modern diagnostic standards and, crucially, for us, how those new clinical rules violently collide with our daily coding and revenue cycle realities. Okay, let's take a quick look at our roadmap. We're hitting the Sepsis-3 paradigm shift, the core sepsis definition, the end of severe sepsis, redefining septic shock, and wrapping up with clinical reality versus coding rules.
All right, Section 1, the Sepsis-3 paradigm shift. Let's dive right into the seismic shift in clinical practice.
So if you're a medical coder or a CDI specialist, you see the code R65.20 for severe sepsis on charts literally every single day. It's a total staple of the revenue cycle, right? So why on earth did the medical community in a massive 2016 international consensus decide this term was completely clinically obsolete? Well, to get that, we kind of have to look at what we left behind.
Back in the day, we had the Sepsis-2 criteria, which relied heavily on SIRS, the Systemic Inflammatory Response Syndrome. It was super focused on general inflammation parameters, things like temperature, heart rate, white blood cell counts. But then, in February 2016, the third international consensus published Sepsis-3 in JAMA. And Sepsis-3 just completely threw the whole SIRS concept out the window. They took the focus entirely off of general inflammation and placed this rigid, unyielding spotlight strictly on life-threatening organ dysfunction.
Moving into Section 2, the core sepsis definition, focusing specifically on that organ dysfunction.
The absolute core of this shift is the exact definition from the Sepsis-3 consensus. Sepsis is now defined as a life-threatening organ dysfunction caused by a dysregulated host response to an infection. Notice what's missing there? Yeah, no mention of basic inflammation. The body's response to the infection has to be so incredibly dysregulated that it is actively causing the patient's organs to fail.
Because of that strict definition, instead of just checking off general SARS criteria, providers are now laser-focused on 6 specific organ systems to diagnose modern sepsis. We're talking about evaluating the respiratory system using the PF ratio, coagulation via platelet counts, the hepatobiliary system by tracking bilirubin, the cardiovascular system through mean arterial pressure, the neurologic system using the Glasgow Coma Scale, and the renal system by monitoring creatinine levels. Bottom line, if the infection isn't impacting these systems to a life-threatening degree, it simply doesn't meet the Sepsis-3 clinical threshold.
And the sheer institutional weight behind this shift is massive. This wasn't some fringe idea that popped up overnight. In March 2017, the Surviving Sepsis campaign officially adopted the Sepsis-3 definition as their authoritative diagnostic standard. Plus, the CDC formally endorsed it too. So, make no mistake, this is absolutely the undisputed gold standard for modern clinical documentation.
All right, Section 3, the end of severe sepsis, and exactly why it became clinically obsolete.
It really all comes down to the phrasing here. Because the new Sepsis-3 definition inherently requires life-threatening organ dysfunction just to even be called sepsis in the first place, that old middle-tier category we used to rely on, severe sepsis, was completely eliminated from modern clinical diagnostic standards. Clinically speaking, there is no such thing as mild sepsis anymore. All sepsis involves organ dysfunction, which makes severe sepsis a totally redundant phrase for a physician to write in a chart.
Which brings us to Section 4, redefining septic shock, the absolute most severe subset of this condition. Under Sepsis-3, septic shock is strictly defined as a subset of sepsis that features profound circulatory, cellular, and metabolic abnormalities, and it relies on a new rule of 3. You need 3 simultaneous clinical factors: persisting hypotension, a strict requirement of IV vasopressors to maintain a specific blood pressure, and an elevated serum lactate level. And the absolute kicker? All of this must be present in the setting of adequate fluid resuscitation.
I actually want to pause right here and really anchor this number in your mind. A serum lactate level strictly greater than 2 millimoles per liter is now a hard, non-negotiable clinical requirement for septic shock. Lactate, as you know, is a byproduct of anaerobic glucose metabolism. When tissue hypoxia or hyperperfusion happens, basically when the tissues are starving for oxygen, lactate spikes. Seeing that number climb over 2, that is a massive red flag for severe cellular dysfunction. Likewise, the clinical documentation must explicitly show the use of IV vasopressors to maintain a mean arterial pressure, or MAP, strictly greater than 65 millimeters of mercury. Think about it this way. If the patient's blood pressure can be stabilized with just standard IV fluids, they do not meet the strict Sepsis-3 criteria for septic shock. The vasopressors are literally the defining line.
Now for the major friction point. Section 5, Clinical Reality versus Coding Rules and the Audit Vulnerability. Clinically, your doctors know Sepsis-3 makes the term severe sepsis completely redundant, but in the ICD-10-CM coding world, code R65.20 is very much alive and kicking, and here is where it gets incredibly messy. Payer auditors will routinely deny sepsis diagnoses if the provider doesn't explicitly write the word severe, or if they don't clearly link the organ dysfunction to the sepsis in their charting. If they just list sepsis and kidney failure as two separate problems, auditors are going to jump right in and argue that the dysfunction is just from a localized infection. To make matters even more complicated, ICD-10-CM guidelines state that code assignment is based on the provider's diagnostic statement, not the underlying clinical criteria. But as we all know, CMS also demands that the clinical evidence be present in the chart to support the code. So if a provider writes sepsis based purely on clinical judgment, but those rigid Sepsis-3 parameters aren't clearly met in the documentation, it creates a massive, glaring vulnerability for an audit. This is exactly why a rock-solid joint effort between the healthcare provider and the coder is absolutely crucial to validate these clinical conditions before the coding even happens.
Navigating that tricky space between clinical intent and coding guidelines is really what separates the good CDI specialists from the great ones. So ask yourself, are your providers documenting to accurately reflect modern clinical science, or are they just documenting to survive the next coding audit? Stay tuned for Part 8, where we master the SOFA score, breaking down all 6 organ systems and the critical baseline adjustment rules. Until then, keep learning and keep leveling up. This is Decode Healthcare with Harshal.